Good morning and good afternoon. Thank you for joining us today. My name is Joanne Ferrara, Marketing Director at DiMedso, and I will be your host for today's webinar on infectious disease and environmental threats and their devastating effects to lungs and the vulnerability of our healthcare systems. Today's panel consists of Dr. T. Guidotti, a pulmonologist and international consultant in occupational and environmental health, Dr. Simon Phaneuf, emergency physician and DiMedso's chief medical officer, and Dr. Laura Mcintosh, DiMedso's VP of clinical applications. We've reserved time at the end of today's discussion for a Q&A, so please feel free to submit your questions through the Q&A panel at any time during the session, and we will either address them during the session or after. And now I'd like to turn it over to Dr. Laura Mcintosh.
Thanks, Joanne, and good morning, everyone. It's my pleasure to be here this morning or this afternoon, wherever you may be, and to join Dr. Guidotti and Dr. Phaneuf for this discussion today. At DiMedso, we spend a lot of time thinking about lung health, and we are very concerned about the various immediate threats to our lungs. Environmental threats and infectious diseases are on the top of our minds, and I'm sure on the top of most people's minds that are on this call today. We wondered about the effect that the decreased air quality caused by pollution and wildfires have on our health and on our lungs. And we also wondered about how mask wearing and social distancing measures due to COVID-19 have changed our immunity and might have long-term effects. Finally, we're very interested in how the increasing rates of COPD and bronchiectasis in adults and asthma and RSV or respiratory syncytial virus in children will affect overall quality of care. So we decided to pull together two very distinguished experts to have a conversation around these issues. I'm very excited to lead today's discussion and learn from T and Simon, both very knowledgeable experts in their own right. Dr. Guidotti is an expert in occupational and environmental lung diseases and is board certified in internal medicine, pulmonary medicine, and occupational medicine. And Dr. Phaneuf is a practicing emergency room physician, a professor of medicine, and a specialist in sports exercise medicine and lifestyle medicine. So the first topic of conversation that we'd like to turn to today is around environmental exposure and lung disease. I read a very startling fact that globally, 9 of 10 of people now breathe polluted air. So this is very frightening. And Dr. Guidotti, I was wondering if you could comment about the short-term and long-term effects of pollution and air quality to health, specifically focusing on our lungs.
Certainly. Well, we've had a revolution in our understanding of the effect of air pollution, specifically on lung health and on mortality in large populations. We used to think of it as a secondary factor in lung health. We now know that that air pollution, and particularly specifically fine particulate air pollution, is one of the leading drivers of death worldwide. We didn't know that before. So as fine particulate air pollution gets worse, we're going to have increased stress for a variety of reasons on the lungs, not to mention the oxidant effect and lung aging, making everything so much worse. We've got worse pollution. We've got oxidant air pollution, including ozone and oxides of nitrogen, that getting increasingly worse under current trends. We have wildfires and the results from sporadic incidents that have a different distribution and effect on their on the lung than fine particulates. We've got release of air toxics, and particularly in industrial areas and uncontrolled emissions. We've got synoptic weather conditions that include sporadic but very severe combinations of heat and humidity that are particularly stressful to people with impaired lung function and that result in high mortality rates. And we've got the effects of disasters, dispersion of populations, mold in rehabilitated buildings, which makes asthma and bronchitis so much worse, and so on and so forth. So the situation is on the verge of getting much worse. We have conditions worldwide that are getting much worse. We have situations in developing countries that are tenuous at best. And we have situations in developed countries, as in North America, where the wildfires and secondary effects of environmental really catastrophes, in the case of climate change, are threatening large populations.
And Simon, I was wondering maybe if you could comment on that, which populations are most at risk for all these insults to our lungs caused by pollution and wildfires. You're on mute, Simon.
Sorry, I think most all populations are at risk because we can't just stop breathing, obviously. Different populations, if we look at premature babies, they're at risk for developing specific child lung conditions such as asthma. As we get older, we have other chronic conditions that are compounded by environmental problems, and everything adds up. When we have an infectious pandemic, and on the other hand, we have other pandemics such as chronic lung conditions and obesity and inflammation. Everything on top of environmental pollution, everything compounds the problem, because everything is an injury to the lungs, create chronic inflammation. And when we're creating chronic inflammation in the lungs, there's a gradual destruction of elastic fibers in the lungs, production of mucus, lingering inflammation that will further damage the lungs. And so it's important to avoid that, because there are long-term consequences to that.
Mm-hmm. And you alluded to infectious diseases, so maybe let's go there actually. So we have these environmental threats. We also have, obviously, everybody's very well aware of the effects of COVID-19, but I think there's downstream effects of COVID-19, and I was wondering if you could comment on how mask wearing and social distancing change the seasonality in some of these other respiratory diseases, such as RSV in children and influenza in adults.
That's an interesting question. We've seen, we have a well-known virus called respiratory syncytial virus that is causing like a cold, generally in adult, or like a laryngitis, but can cause a more severe disease in babies called bronchiolitis. And normally there's a seasonality. We see this disease mainly in the fall and early winter, and due to probably preventive measures for COVID last fall, we didn't see any of that. And now we've started to see a rise in RSV cases at the end of the spring and early summer, which is unusual. Interestingly, we could have been tempted to believe that we'd see the same with the common flu, but we didn't. So we don't know why RSV is on the rise at an unusual moment, and the flu is not. One theory is that the herd immunity towards RSV hasn't been stimulated last fall, thus has declined, leading to this outbreak. But clearly, there's a change in seasonality.
Interesting. T, on the same line of topic, thinking about COVID-19, I was wondering if you could comment about some of the long-term post-COVID-19 effects, apart from RSV, but which is not linked, but other direct effects of post-COVID and how that affects the lungs.
Well, I think that post-COVID is turning out to be a very complicated area, and we're going to be seeing the emergence of subsets of population with different characteristics. Long COVID, obviously, but there will probably be different types of long COVID, and depending on the amount of fibrosis and the compromise in host defenses. These people are going to have an awfully hard time getting back to normal daily life and getting back to work. So we have an impairment and disability effect in the best case scenario, where these people are going to find it very difficult to go back to normal lives. In the short term, we have the problem of getting these people adequately treated and optimally treated and fine-tuned, not only so that they can get over the disease, and not only so that they can get through the period of vulnerability to get complications of the disorder, but also to prevent disability, to prevent the deterioration that's going to interfere with their future lives. Or we're going to have a great many people who are never going to go back to regular daily life, and whose opportunities are also always going to be limited by this catastrophic disease. A lot of that has to do with getting optimal treatment early and nipping the disability in the bud. It is a form of prevention. It's tertiary prevention. It's prevention of disability and impairment.
And so we have these patients that obviously are landing in hospital and ICU because of COVID and also because of environmental factors. We also have long-term effects, post-COVID, people recovering, plus I guess long-term rehabilitation after wildfires and pollution. How does this overall affect, what does this mean for the quality of care? Simon, I'd be interested to hear from your perspective on an emergency room doc, how that affects your life.
Yeah, it's very interesting because I mean everything is intertwined. We've seen a rise in COVID cases in places affected by wildfires, for instance, and then at the same time, if we see a rise in respiratory syncytial virus along with COVID and lung conditions by wildfire, I mean the healthcare system can often be overwhelmed. And this leads to cancellation of other surgeries. I mean, cancer patients cannot be treated, and many states currently, many states in the States are in dire straits because of that. So everything is intertwined, and we have to look at the whole. And again, talking about long COVID and the potential for long-term disability. A very, very significant of hospitalized patients, and the number varies, but it's about 1 in 2 at least will have long-term problems. And this is significant. And the best way to avoid that is to have a preventative approach where, I mean, if people have less comorbidities and prevention and vaccine uptake can't prevent severe COVID hospitalization and long-term problems, because there's a clear correlation between severe COVID and the chance of having long-term problems and long COVID. So if we can prevent severe disease, we have an opportunity to decrease the long-term problems. So prevention is very important. Unfortunately, in real life, it's very hard to do, as we saw. And then there's secondary prevention, preventing complication once you have the disease and going into aggressive treatment. And it's been shown that, again, for COVID, that enticing patients to move, to breathe, and to mobilize the patients is reducing the severity of the disease. And that's something we should do. Unfortunately, we've seen many physical therapy societies and respirologists advising against physical therapy because they were afraid of generating aerosols, and they were afraid for the caregivers to get infected. But I think it's somewhat of a mistake, because if we entice patients and if we treat aggressively those patients in the acute setting, we can potentially prevent long-term complications as well.
Mhm, mhm. Teague, would you like to add anything? I'm curious to hear your thoughts on treatment routes and go ahead.
Sure. The I come from a public health preventive medicine background, in addition to my training in pulmonary medicine, and in my world, we speak of primary prevention as being protection from the disease itself. In other words, we're preventing it from starting in the first place. And we've done a very spotty job of doing that in the case of COVID. And it doesn't look like we're going to do much better going forward in terms of a lot of other respiratory threats. I'll get back to that in a moment. Secondary prevention is early detection and intervention so that you get the best possible outcomes for the disease itself. And that's what Simon was just discussing. That depends a lot on optimizing treatment. So you not only get through the short-term illness, but you also reduce the risk of complications and reduce the impairment, such as the fibrosis and the impairment of host defenses that goes along with this. And then there's tertiary prevention, which is a standard term in my world. And tertiary prevention is all about preventing impairment so that people aren't disabled after they recover. There are methods of doing that that are in addition to but different from the optimizing treatment, but it's extremely important to ensure that these people can live decent lives and functional lives and rewarding lives after they recover.
Mhm.
Could I make just one comment? And that's that we may have been lulled into a false sense of complacency in the last few years. I think that we may have been going through a kind of golden age of lung health that to some extent has misled us into thinking that things are better were better than they are. I think that delusion is about to be shattered. We had great success with smoking cessation. We had great success with vaccines up until the behavioral failures that are complicating our management of COVID. We have had much better treatment for asthma. We've had improved cardiovascular risk factors, which meant that the mortality from lung disease got better. And we've bottomed out in terms of the prevalence of bronchitis. These things aren't going to last forever. And they're certainly not going to last forever without work. We've got climate change dramatically changing the world we live in and making our environment much more hazardous in terms of lung health. We have secondary effects of the climate change, including wildfires we've talked about, and increased air pollution at ground level. We've seen behavioral changes in our population with alarming resistance to even basic measures to conform to public health and protective measures such as vaccination and ICU bottlenecks, which are predictable effects of saturating the healthcare system. Healthcare system needs help. Technological help that reduces the workload on respiratory therapists and so forth. These are all coming together. And the future is going to be a lot more problematical than the past in terms of lung health, I predict.
Yeah, and all these factors are compounding to, it's an assault on the lungs. So, I mean, the next decades will be, it'll be a challenge to treat respiratory diseases.
And all of these diseases have, I think, a common theme, or most of these diseases have a common theme, which is excessive mucus in the lung, which particularly with COVID-19, I think some people think it's a dry cough, but there is also a lot of patients have this mucus-filled lung. And I think you alluded to that fact, Simon, that airway clearance and physiotherapy will play a huge part, whether it be manual physiotherapy or physiotherapy from devices.
Yeah, I think the common factor is probably inflammation. In some cases, it'll lead to destruction of the lung tissues, and in other patients, it will lead to mucus protection, bronchiectasis, dilatation of smaller bronchi. All the factors, climate change, pollution, infections, they all increase inflammation, and this inflammatory process leads to lung destruction and secretions. Yes.
And I think before we were talking actually about the issue with lung transplantation. I like your perspective on that.
Yeah, unfortunately, with aging populations, comorbidities, and the impact of COVID, I've seen chest X-rays and CT scans of COVID consequences on the lungs, and they're horrific. Those patients will need lung transplants, and it's questionable whether we're going to have enough lungs, healthy lungs, to transplant for those patients. It's a serious issue, and again, I think we need to prevent primary, secondary prevention, and tertiary prevention to prevent complications. We need to treat COVID patients aggressively to try to minimize long-term consequences.
Particularly, I guess, now with the children being affected so much more by the new variant, and they're not protected because they can't be vaccinated. So something that we need to consider.
Can I make a comment about that? Actually, two comments. One is that we're talking about host defenses of the respiratory tract. We're talking about diseases that injure the lungs specifically, but we're also talking about diseases and an increasing number of conditions of daily life that impede the ability of the lungs to protect itself, that reduce clearance of mucus, for example, that do not oppose the oxidant injury that occurs in the lung from inflammation or directly from oxidant air pollution. These natural defenses of the lung are impeded so that the lung can't fight back as well when it's not in addition to the direct damage that's being done. And if our treatment is impaired, for example, lack of access to ICUs or not being able to provide the standard of care that we would like to, because our respiratory therapists are overextended and hospitals can't provide that level, then the ability of the lung to get through and to fight off the infection for itself disappears.
And I think that's important to have a two-pronged approach, where on one side we're treating inflammation, and we have medications to do that, and on the other hand we also have lung clearance devices to clear the lingering secretions from the lungs, because if we leave those infected secretions there, they're also promoters of inflammation. Yes, so I think we need a two-pronged approach.
Well, it's been a very sobering conversation, but you have given some guidance and hope. I think I know that there are a number of people online, some respiratory therapists. It would be interesting if there are any questions from the group that are listening to our two experts. We'd be happy to take them now.
Well, I do have one in the queue, and it kind of goes back to your presentation last month, Laura, around the impact on the healthcare system. With everything that we just talked about today, could you tie that back to hospital length of stays, ICU length of stays, and readmittance into the hospital, and just kind of give the facts and figures that you shared in last month's webinar here for this audience?
Sure. So I mean, what Simon and T have been saying really aligns well with the results from a study that we performed in Quebec, showing that early intervention with airway clearance is an effective strategy for treatment and can keep people out of the ICU and reduce the overall burden on the healthcare system. In Canada, and I believe it's very similar in the States, the length of stay in ICUs has increased significantly with COVID. The average stay in Canada was 7 days pre-COVID, and now it's between 15 and 21 days total for people with COVID. So clearly, anything that can be done to reduce that length of time not only saves, obviously, the healthcare system, but also improves quality of life and all these factors that our two doctors have been talking about, with hoping that long-term effects aren't as bad and rehabilitation efforts are not as good. So anything that we can do to start treatment early and help the lungs recover early, hopefully stopping people from going to ICU and being ventilated, is clearly a huge step forward.
We actually do have another question. It's going to go back to the RSV topic. Is it, I'm not really sure if I'm reading it correctly. Is adult RSV growing as fast as pediatric RSV?
What's the question?
Again, I
Yes.
apologize if I'm not phrasing it correctly. Is adult RSV growing as fast as pediatric RSV?
Well, I don't have recent statistics, but adult RSV is generally just like a cold. It shows like a cold, and oftentimes it's the cause for laryngitis, where you lose your voice, or you have a hoarse voice. And it goes underreported because adults are not as sick as babies. So we don't have good statistics, and I have no current statistics to see if it's on the rise right now. I just know that we have more babies coming to the emergency room for bronchiolitis related to RSV. I don't really have adult statistics.
And it's
To
interesting.
follow up on that.
Oh, sorry. I was just
Nope.
going to. It was interesting that you said, Simon, that the influenza in adults though hasn't increased. At least
No.
we haven't seen it yet. So it's kind of it'll be interesting to watch.
Well, that's a good side of this pandemic.
Well, coincidentally, the person who asked the question actually gave some more clarification as to why they were asking the question. Just simply that they are seeing more severe adult RSV cases than they had never seen before in Tennessee. So this person is from the Tennessee area.
Interesting. It may be related maybe to quality of air. Maybe also because we haven't seen a lot of RSV recently. Maybe immunity is waning. It's interesting.
Yeah.
Another question has come in more. Oh, did you have more comments for that, T?
Well, I was just going to say that bronchiolitis is underappreciated. It sounds benign. Sounds like there's something that people they get over quickly. That's not necessarily the case. Bronchiolitis can leave a long-term predilection toward diminished lung function over time as an individual gets older. So it's not as benign a condition as the general lay public tends to think it is.
Okay. We do have one more question, and it's a deeper dive on the environmental impact on COPD. And what can we do to help? How do we treat these individuals?
I think the short answer is well, and with everything we've got. And that means taking advantage of technology for removal of secretions, for helping people to breathe in ways that are that don't necessarily require intubation. It means helping them after intubation to get back on their feet lung-wise. It means building exercise capacity and rehabilitation after the event. And it may mean an increased emphasis on self-care and on family care for individuals who are over the hump but aren't ready to go back to daily life or work, because we need technologies that an individual can use themselves and at home to continue to recover and rehabilitation without the need for tying up expensive technology and also hospital personnel at a time when we have shortages in our healthcare system is so impacted.
Okay, I have another question actually from a respiratory therapist who's been a respiratory therapist for over 20 years and is familiar with different high-tech airway clearance devices, but is asking specifically, are there some devices that are more effective than others? And I think I'm going to address this one to you, Simon, to talk about the strengths and weaknesses around different types of technology in airway clearance.
Yeah, again, it's very, we don't have a lot of comparative studies, so it's very hard to differentiate between and be certain about different technologies. It amounts to often to the practicality of one technique over the other. For instance, we know that some active devices are hard to use for some patients, like the flutter valve, and they're not very effective. Other devices like the vest are bulky and difficult to use. So it's more a question of practicality, I think, of those devices. The frequencer, for instance, is a device that the patient can use by himself and can be used also on intubated patients. I think it goes more to that, because having very good prospective randomized trials comparing different techniques, I mean, we don't really have that. I don't know, T, if you want to add to this.
Well, I'm trying to avoid getting into a situation where we're addressing specific products, because that's not the purpose of this webinar. But I think that if you tick off the desired characteristics of technology, you'd like something that doesn't tie up healthcare resources, that actually frees healthcare resources, that's comfortable and acceptable for the individual use, that's highly effective and can be used by the individual or their family. So I think that that's going to be a set of criteria that we would apply looking for an optimal solution. And I think that there are promising technological developments out there. I think that this could be a very useful contribution in the future.
And I think the right, I mean, again, when the only tool you have is a hammer, everything looks like a nail. I mean, we have different tools, and they may be more appropriate depending on the setting and depending on the patient.
Yes.
Right. That makes a lot of sense. One last question, just to give a little bit deeper dive in the impact of environmental issues on long COVID. So I think we talked about long COVID, but really maybe tie it back with the environment.
Mm-hmm. Yes, I think that we're only having our eyes open to the possibility, or to the many dynamics that are going on, that converts the lung that's in that precarious state of potentially slipping over into long-term chronic injury from a compensated condition. The lung in the transition from health to disease is the name of a book on this topic many years ago that really is kind of a Bible in those of us who have been thinking about this for a long time. We need to stop that transition. We need to figure out ways to repair the lung, because the lung doesn't regain function after it's lost. We need to figure out ways to do that. Part of that may be mucus clearance, so that there isn't plugging, and so that more of the lung is freed up for gas exchange. We need to think in terms of comprehensive lung care, and we need to stop wishful thinking, because these problems are not going to go away. They require concerted effort with technology. They require society to really look long and hard about behavior in the populations, and about public health. And we need to think of dysfunctional and wishful thinking in terms of climate, in terms of vaccine, in terms of hospital and healthcare capacity, and realized that we really are sliding toward a crisis.
Denial might be comforting, but it's not a long-term solution.
Yeah. Yes,
Well-
and how to break through that and to promote health has been a long-term problem in public health. It's now approaching crisis proportions because of the intersection of all these different adverse developments.
Thank you for that. And Simon, if you have anything you'd like to add, I think it's time for just closing remarks.
Well, thank you all.
Laura, any additional closing remarks before I wrap us up?
No, I mean, I'd just like to thank our two panelists for the very engaging conversation and for their perspectives. And I've learned a lot, so thank you for your time.
Yes, I
Thank you.
thought today was
Thank you.
really quite interesting. I want to thank you all for your insights. I'd also like to thank the participants of today's webinar for contributing such great questions as well. So thank you everyone for joining us today. If you joined us late, you could certainly find this webinar on our YouTube channel. We look forward to you attending another webinar of DMEDSO in the near future. Thank you again and have a great day.
Thank you.
Bye.
Thank you.